Good evening, tēnā koutou. Welcome to our webinar tonight. I hope you have had an enjoyable day today, an extra holiday for most, but I am sure some of us have been on duty. This evening, our Haematology session is run by the Section of Rural Health General Practice Department, University of Otago, and supported by the Rural Hospital Medicine Division of the Rural New Zealand College of General Practice. It is endorsed for 1 hour of CME, and if you would like me to claim these CME points for you, please complete the questionnaire at the end and enter your medical council number. Please remember I can only do this tonight and not beyond. We are trying a slightly different format this evening, so look forward to your feedback. I would just like to quickly highlight to all of you the Leaning on the Fence Post website, where the webinars and the podcasts and much more are loaded. For those who were here earlier, I had it screen shared, but I'll show it to you again shortly. I will send the link to our rural mailing list this week. So without further ado, I would like to introduce Elayne Knottenbelt, a consultant haematologist who works at Palmerston North Hospital and at MedLab Central. She also has close links with Hawera Hospital, doing much case-based learning with the doctors there. She is originally from Zimbabwe, where from our discussion, she has developed a focused, concise, and practical approach that we will all appreciate in rural practice. Thank you very much for your time this evening, Elayne. You are very, very welcome, and I really do appreciate it on this day off.
Well, I really appreciate you all turning out on a Monday night of a holiday.
Yeah.
It's been a glorious day here, but I did take a moment to watch New Zealand's acknowledgement of Her Majesty and to welcome in King Charles III. I guess I've formed a lovely relationship with the staff at Hawera Hospital over my lunch hour to just chat, really. And I think the format kind of works partly because I'm quite time poor and I don't have time to endlessly prepare fantastic PowerPoints, and my skills there are quite low. But I love hematology, and I love it for the fact that you see the patient, you do the diagnostic test, which may or may not include a bone marrow, and then you see them back in clinic, give them the good or bad news, and then make a treatment plan. And a lot of my patients are with me for like 25, 30 years. And I find all that quite rewarding. And I think you've all been sent the algorithm for the approach to anemia. And I encourage you to get that in your lizard brain and adapt it to suit your clinical practice and the kind of patients that you see. I originally designed this because I did some work in a laboratory in Vietnam where we still have a relationship, just trying to help the laboratory staff have an easier way of helping the doctors there as to what, how to approach anemia. And thanks for those who've taken the trouble to send in questions and things. The referral patterns that we get are very much in keeping with the questions that you're asking. So I think we're in for a fun evening, and welcome the feedback on this sort of what Lucinda tells me is a different, more sort of informal format, which I hope will be entertaining since you've given up your Monday night.
I'm sure it will, Elayne. When I send out a memo for specialists to help us with these webinars, and you got a ringing endorsement. So obviously the format you use in Hawera is very, very well appreciated and well received. So yep. I'm sure it's going to be great.
Yep. So should we just start with the cases and things?
Yeah.
Should we?
Yeah, go for it. Yep. If you screen share.
Yeah. So basically, this is focusing on anemia and iron studies by request. And so we're just going to zap into a case, and thanks to Mark for providing the cases. When you're asked to provide cases, I'm sure none of you can even think of a case of anemia or iron that you've ever had. So, or maybe you're just sort of time poor. So I think we all see in practice tired 40-year-old females with a zillion causes for that. And it doesn't take much in the history to realize that she's a busy lady. She's got 5 children. She also has menorrhagia, and in some communities this is just thought to be normal. So she has a blood test, and it's interesting to notice here. I can't get your feedback to notice, so I'll just give you a couple of minutes to have a look at it so you can make your own thoughts about what might be wrong or unusual. Obviously, on the history alone, you're going to ask for iron studies. So just give you a pause to look at that, and we'll go on to some things. So what is a bit unusual? What other tests might you request after the clinical history, and what is the treatment you would offer? So I don't know if you noticed, but she was quite microcytic with a low MCV and a low MCH, but her hemoglobin was 110, which is surprisingly good for somebody with that history. And that might prompt you to think, well, I mean, probably a hemoglobin of 110, if you saw that, you wouldn't make too much fuss about it. But you can be incredibly, incredibly tired just with a low ferritin, even if you've got a reasonably normal, hemoglobin. So in terms of the other tests, I think you need to add B12 and folate. She's a busy mum. She's probably socioeconomically not able to source a lot of meat. She might not have fresh fruit and vegetables. So just remember that there are other causes other than the iron deficiency. In this case, you don't really have to investigate the cause of the iron deficiency because it's pretty obvious from the clinical history. So she does not need to be referred for colonoscopy, which seems to be the reflex thing for iron deficiency, obviously. So anyway, she gets Ferinject. Now, did she need Ferinject? To get Ferinject, you have to show an intolerance to oral iron or lack of response to oral iron. And maybe her reasonable hemoglobin suggested that she had tried some iron in the past. So just remember that if you're referring or signing up for Ferinject, you must demonstrate that you investigated the cause and that you've tried oral iron. And quite honestly, oral iron is can be quite well tolerated if you just take 2 or 3 a week, and you can catch up quite nicely if you're not in that super severe setting. So 2 months after Ferinject, she is sorted. Her MCH is still a little bit on the low side, which is interesting. So the question is that job done? And what does this result tell you and exclude? And that's because in certain populations there is a background thalassemia, and this is where looking at your previous results helps a lot, because sometimes people might have a mild anemia and a microcytosis that goes back as long as forever. In which case, and I can't ask you, but hopefully in your head you're looking at the algorithm for microcytic anemias. And if it's not iron deficiency, there's thalassemias in there. And with our populations now, we see a lot of thalassemias, and a lot of the Maori population have an alpha thalassemia trait, which can give them a microcytosis. So although that sort of seems on the face of it quite simple, and I would say here, I just hope this poor lady had a B12 and folate level done as well. She responded brilliantly. So, you know, that's all quite encouraging, isn't it?
Mm-hmm.
Yeah.
Can you just go back, Elayne, to the first, to your first slide with the results?
Yep.
And you may be going to talk about some of this, but I just wanted to, in my lab, we often just use a ferritin. Like that's what we've been told to use just as a ferritin and not to do a full iron panel. So what would you say to that? Or do you do that in?
If it's straightforward iron deficiency, I don't ask for full iron studies. if it's a menorrhagic setting. But I think that if it comes back with a low normal ferritin and you haven't done a saturation, you kind of kick yourself, because
so can you explain around the importance and what's the usefulness of the full and what it differentiates for you?
Yeah. So basically, ferritin actually is not. It's a sort of very downstream effect indication of your iron stores, but ferritin goes up as an acute phase reactant, obviously. And if you've got an associated chronic disease or you're going to get a low iron deficiency, should have a low saturation, and in chronic disease less so. So you're looking for that. And the other thing back on the full blood count, I actually don't know how to go backwards. When I press page up, it doesn't work. So I don't know how you go backwards, because I'm pressing enter on here. So I'm finding going backwards.
And the arrow won't help you on going backwards unless you stop slideshow.
Oh, yeah. Anyway, we won't worry. Basically, if you look at the MCH as well as the MCV, a low MCH is really indicative of iron deficiency as well. So
Right.
I think because you're sort of all watching the lab budget, I don't know how your lab tests are, how much you're controlled, but the cost is in taking the person taking the blood in the tube and getting to the laboratory. The actual cost of the test in the laboratory, whether you add a saturation or not, is very low.
Okay.
And if you have to go back and do a second test, that's inconvenient for the patient. And so I always feel, particularly if you're investigating a fatigue patient who may also have iron overload, where you definitely need your saturation, I would encourage you to do the full iron studies.
Okay. And what's the benefit, or in what situation would you use a soluble transferrin receptor?
I don't.
Never use it?
No. And we've had a chat about that amongst the laboratory hematologists, and it's occasionally useful if you're really dithering about what the cause of the iron of the anemia might be, and you've got equivocal iron studies. I have never requested one. I've been around a long time, and it's a bit like haptoglobins. I don't request many of those either. Yeah. So I think it's a fancy test, but I don't know that it adds a lot
much,
except for very rarely. And now that'll be an expensive test. So you're much better to use the things that you've already got, which is your MCH and your percentage saturation. And sometimes just a jolly trial of iron, like
good old school.
Good old school stuff, and then not missing. Remember, if somebody's chronically iron deficient, you get like an atrophic gastritis, so you can get B12 deficiency from long-standing iron deficiency, and vice versa. If you've got B12 deficiency from atrophic gastritis, you don't absorb iron. So they're those sort of reciprocal things. Our lab are quite reluctant to do folic acids. And I think with dietary stress at the moment, with fresh fruit and vegetables being hard to get, and poor diet choices as well, folate levels can be really, really low. They've got to be interpreted with caution. We used to do the red cell folate, and then they just do the serum folate, and that of course is very has a lot of variations. But honestly, if you've got a folate of 3, you're likely to be folate deficient, and then you would do that. Yeah, does that make sense?
Sure does. Mark's arrived. Can you see a smiley face? Hi, Mark.
Kia ora koutou, everyone.
Kia ora.
Apparently, when you're putting down 2 children, time seems to fly.
It does. But don't worry, we've got it nailed. So you can just sit back and relax, mate.
You can be on the chat. So Mark is one of the rural hospital doctors in Hawera, and he's helping us with this evening's session. So like most of us, got sidelined by children or others. So very welcome. Great to see you.
Oh, so why have I jumped to the end? That's not right.
Mark may be useful on this technological side of things.
So I will just stop share for a minute because I can't see, I don't know why it's jumped to the end.
No.
Why has it jumped to the end? That's
Otherwise we
ridiculous.
can get Mark to, have you got the
I've got the cases up, but I've got the cases that we
Elayne
went through.
altered them a wee bit. Have you altered the
Yes, okay.
PowerPoint, Elayne?
Oh, hang on. It's all right. I can just do this. Like I can do old school way.
Yep.
There we go. Yeah. Right. So you wanted to just review that. This is post-treatment. Notice her MCH is low.
You'll still have to screen share it,
Oh,
though,
I do. Yeah.
Elayne.
So where's that gone now?
Down the bottom.
Yeah, it's just not showing actually.
Slide your mouse down.
Yeah. No, there's nothing there. Hang on. This is very odd.
You've got a very relaxed crowd, so don't panic.
I know. It's just like all I can see is the whole case. All I can see is my PowerPoint presentation. I can't see anything else on my screen whatsoever.
Oh, I see. So go down the bottom and find the little blue. Can you see the little blue zoom at the bottom?
No, all there is just the PowerPoint. There's absolutely nothing else. I've never seen that before.
Go up to the top.
Try hit escape. Escape.
That's yeah. So let me get back to my Zoom. That's what I need to do. Share screen. That's going to be the way to go. Now I'm in control. So we'll do from the beginning.
We can just do from current slide. Go across from current slide.
Yep.
Is that the one you want to be in? Or do we need to go back slightly?
No. Here we are. Can you see that? Complex case number 1? Perfect. Sorry about that. You can tell I do this a lot. I'm a face-to-face girl myself.
Yeah.
So this is a case from Mark. So thank you, Mark. So this is a 3-year-old girl going to a GP with a viral type illness. She's got a pale complexion and it's unclear if it's new as she has got ginger hair and she's possibly jaundice. Good old clinical exam, hey? I'm not quite sure. I suppose people who do have ginger hair do have often a pale complexion, but in my day we used to do this. Looked at the conjunctiva in Africa, that was our hemoglobinometer. When I look for anemia in my patients, I look for pallor in the palm creases, which is also quite a useful thing. So she's possibly jaundiced, and I thought, well, this is a time to think, well, what else would you ask the mother? Is this worth investigating? And what tests would you request? So just a little moment to think about that. And tests were requested. And you can see she's anemic. Now, it's important to notice that the hemoglobin range in children is a little less. That's also true in young children of lymphocytes. If you look at the lymphocytes there, the lymphocytes can be up to 8. And the monocytes are higher. So when you're dealing with children, do take note of the normal range, because it may seem alarming, but it's not. So in an adult, a hemoglobin 95 is quite low, but in this little girl, it's only mildly low. And also look at her MCV. The MCV range is lower as well. So you might think an MCV of 76 is low, but in fact, it's actually normal for a 3-year-old. So just remember that. And notice in red, isn't it nice when they pop up red? but do familiarize yourself with the things that are in black as well. That she's got metamyelocytes and nucleated reds. So hematologically, we would call that a leukoerythroblastic blood picture. I don't know if you've ever heard of that, but it's quite cool. It's one of the hematological favorite things. So she's mildly anemic and she's got the odd nucleated red cell and a bit of left shift. And the other thing that you notice in red is that you've actually done reticulocytes. Now, Mark had to show me that the reticulocytes had been done, because I always look for them at the bottom, because in our lab format, the reticulocytes are always at the bottom. It makes sense to put them at the end of the full blood count, the red cell parameters, but quite honestly, that's probably going to be one of my biggest messages to you, is that reticulocytes are never done enough. So any new anemia that you have, you should be asking for reticulocytes. And the reticulocytes are super high. So I'll just give you a moment to think, what do high reticulocytes tell you? So basically, high reticulocyte counts tell you that the patient's hemolyzing or bleeding. Now, clinically, you've noticed it's jaundice, so bleeding isn't on the cards. And why would a 3-year-old be bleeding? It would be obvious, and I would say 3-year-olds tend not to bleed unless they've got a bleeding disorder or seriously injured or something like that. And notice the high bilirubin of 60, and you get an unconjugated bilirubin as well, which is terribly helpful. The rest of the liver functions normal, so the high bilirubin with the jaundice pale child is going to be hemolysis. Hopefully you're all saying, yes, hemolysis, hemolysis. And then you have, what next? Why hemolyzing? A 3-year-old hemolyzing. So you can have a little think about that. And this is where the blood film comes in. So those were just some things to remember. And if you go back to your algorithm, you've got had a normochromic normocytic anemia, and you can see one of the major suggested investigations is the reticulocyte count, and next on the list in your algorithm is a blood film review. So when you've got hemolysis, there are three parts of the red cell that can be affected. One is the membrane, the enzymes, or the hemoglobin. Those are 3 things that can go wrong. So if you look at a blood film, you're going to be able to see those. And some of you may remember that if you've got G6PD deficiency, you get bite cells. If you've got hemolytic uremic syndrome or fragment hemolysis, you can see fragments. And of course, there are all the thalassemias which have target cells and all the rest of it. So it's really exciting looking at the blood film. So I've done this, and just a reminder, like what I notice when I'm teaching is that people, when I say, well, what does MCH stand for? What's MCHC? So just take a moment to think about whether you know what the MCH and MCHC are. The MCV everybody knows, and the algorithm starts with microcytic, normocytic, and macrocytic based on the MCV. But the next line down of the MCH, that's the mean corpuscular hemoglobin. That's how much hemoglobin is in each cell. So if you've got a huge big cell, the MCH is going to be high. And if you've got a tiny cell, the MCH is going to be low. And then the MCHC is the mean corpuscular hemoglobin concentration, which is like per unit area. And often if you've got spherocytes, for example, your MCHC is going to be high because the hemoglobin's packed into a tight ball, if that makes sense. So really, you need to look at the blood film comment The scientists do it. If it's a complex case, it'll come through to a hematologist wherever you are. I'm sure you all have a referral mechanism for slides to go to a hematologist. And if you in a hospital where there is a lab, like in Haura lab, they would just love you going along and saying, I'd love to look at that film. And they would just love to show you and give you a little hematology lesson and engage and really look after your laboratory, because they don't often see the patient. And if you went and said, I've got this pale 3-year-old girl and I think she's jaundiced, what does the film show? You're going to get satisfaction, and so are they.
So there's a question there, Elayne, about whether rural labs can do the blood film.
Oh, they will all. They should, unless they're a tiny lab. I think it does depend, but I would imagine unless you've got just a little stat lab. I suppose it depends how rural. That's a good question. I mean, Haura's got quite a decent sized lab, fair to say.
There's no time frame in terms of the sample deteriorating that you can't interpret it?
Yes, there is.
That would be the biggest issue.
Yeah, it's probably 24 hours, but it's actually quite a simple thing to be able to make a slide, even if you can't stain it. So I don't know. You'll have to talk to your labs and see what the facilities are. I can't exactly know. I don't know how rural the labs go. I don't have like Wairo, I'm sure can. I mean, that's a town lab, but it's a
one thing, I guess,
small
from
lab,
my experience,
and they will refer to their skill level.
So sometimes the labs the people working there, depending on who's on, might have the skill set to look under the microscope and tell you what's going on, but may not have the lab might not be certified to write the comment, as would be the case for other cell counts on other fluids. So sometimes you can maybe get behind closed doors. Oh, this looks a little bit like so and so. But I can't write anything on the paper.
And I guess that's really important if you're looking at a pancytopenia and they're blasts there. That can give you a 24, 48 hour heads up, which can be super, super helpful. Yeah. So we have this comment. They've noticed the high reticulocytes. And reticulocyte counts, notice, are presented in two ways: as a percentage, where the normal range is above 2%, or as an absolute, where it's above 100. So that can be a bit confusing when you get those two methods, and it's quite easy to calculate, and the automatic analyzers will tend to give you both, I think. And there you can see, looking down the microscope, there's spherocytes and there's polychromasia. Now, I don't know if you know what polychromasia is, but those are the sort of bluish red cells because they've got residual RNA. That means they're young. So when you see polychromasia, even if you don't get a reticulocyte count, if you see polychromasia, then you're generally dealing with bleeding or hemolysis. So you can sort of shortcut there. So they said consistent with hereditary spherocytosis. But can you think of some other causes that you can also get spherocytosis, maybe less common in a 3-year-old?
So Elayne, if you hold for 2 seconds, if anyone wants to put it in the chat, because I'm going to admit that my hematology is very, very minimal.
So have a little go.
Spherocytosis. The other question I wanted to ask you, Elayne, was, we have in that breakdown of all the white cell counts, you mentioned about the monocytes and there's also basophils. At what relevance and when are they relevant? We don't need to ask that right now, because I'm just
we've got a case coming up, that lovely one from Rarotonga.
Okay, cool.
That actually mentions the significance of basophils, and we'll hold that question for that case because there's a lovely illustration of white cells. That's basically there's a lot in that case that we can discuss the white cells. Do you think that's okay?
Perfect.
Yeah.
Okay.
Yeah.
No
So
one else knows anything about spheres.
Oh, right. Okay.
Oh, here's Roma, autoimmune hemolytic anemia.
Well done. Well done. Yes.
10 points
You
to
could
you,
also,
Roma.
yeah, good. Sometimes post-splenectomy can have spherocytes, but usually with other abnormalities. Yeah, so basically the two big ones would be autoimmune hemolytic anemia and hereditary spherocytosis. So I guess the next thing is how are you going to differentiate? And what other
Come on,
tests
Mark.
are you going to do? Right, you're going to do, we used to call it a Coombs test, but it's a DAT for warm autoimmune hemolytic anemia. And that can be caused by medication. I remember having a case of a lady who went for some gynae procedure and she got put on a cephalosporin prophylactically, intra and post-operatively. She was unaware that she'd been given an antibiotic. She went home and she just became increasingly weak. And so she phoned the doctor and they said, oh, you must have an infection, gave her some more cephalosporin. And eventually she went to the toilet at night, cracked her head, went into the emergency department, and her hemoglobin was 46.
Wow.
And her bilirubin was high, and she was full of spherocytes. And that was a case of cephalosporin-induced hemolytic anemia. So medication is really important.
Elayne, what does DAT stand for now?
Direct and anti-globulin test.
Thank you.
Yeah. So basically that is looking for the presence of antibodies on red cells, for an autoantibody on red cells. And so it's an anti-antibody that makes the red cells stick together. And it's quite cool. So if you've got a blood bank, you can go and ask them to show you what a positive DAT is. I think these sort of things are quite sort of tangible and nice, really. That's what I like about hematology. I love the fact that I can actually visualize. My medical school training, I just did hundreds of DATs and cross matches and coagulation tests and all these sort of things. They do less now, but it was super fun. Then if it is hereditary, hereditary spherocytosis is autosomal dominant. So, like who's your daddy? One of the parents should have hereditary spherocytosis, and quite a lot of the siblings. And you may get a history from them of like periodic jaundice. And when they get viral infections, the bone marrows turn off. So they're normally maintaining their hemoglobin by like a huge marrow drive. But when you get a viral infection, it turns off, so their hemoglobin drops precipitously. And that's called an aplastic crisis. And in hereditary spherocytosis, a viral infection that does that quite famously is parvovirus, I guess, which is something that's quite hard to. But any illness or infection can cause either a hemolytic crisis or an aplastic crisis. And they may or may not have a big spleen. It depends on the severity. They can be very mild to very severe, needing a splenectomy, which you try and not do in a child. You try and leave it as long as possible because the risk of sepsis is so high. So you try and keep that going. Yeah. Does that make sense?
Mark has a question for you, Elayne.
Well, it's sort of a question based on an experience that I had in GP practice, where I saw a kid who was about 11, I think 12 actually, coming in with a viral illness, same, maybe slightly jaundiced in his eyes, but said he often gets it when he's unwell.
Yeah.
And went ahead and did an HB that had dropped to, I think, 70 or so.
Yeah,
but the reason I did the HB was because he had a postural tachycardia. So he stood up and his heart rate sort of climbed to 130.
Yeah.
But his resting heart rate, his resting blood pressure was fine.
Yeah.
And it made me reflect on, we see people with an acute HB drop usually in the context of a big blood loss, and they would have,
Yeah.
more like the signs of shock and a tachycardia and things like that would be a bit more obvious because their blood volume itself is smaller. Whereas someone's acutely hemolyzing, their blood's not effective, but they're not lost any blood. They're still the same amount of blood. So maybe do we need to look out for different signs of acute drop?
The acute drop of hemoglobin without volume drop is still really can be absolutely catastrophic, and they'll feel absolutely awful. And remember, there's a lot of stuff for the kidneys to process. And so you might actually even get hemoglobinuria if it's that acute. Yeah.
So doing NSU might be able to screen for the hemolysis as well in the office, because that would be quite useful as well.
And remember, there's if people are passing discolored urine, there's a difference between hematuria and hemoglobinuria. And then again, you can go to the lab and you can look at the color of their serum, which is also quite fun. Yeah.
That chap ended up having an HB dropping to 60 and had 2 units acutely. So
yeah. And by the way, if people are having a bit of a hemolytic crisis and things, do give them folic acid. In fact, people with hereditary spherocytosis or any hemolytic condition should really have folate supplements because the demand is quite high. And just another interesting point here, because we're talking a little bit about iron, they'll often have high ions, high ferritins. And you might want to think why that might be.
And Elayne, I just to finish that case, I wondered, was the ginger here a clue to some?
No, not at all. No,
ancestral...
I think no. There's nothing. There's nothing in that. I just think it makes pallor difficult to tell because often they have that sort of Celtic skin of so always having pallor anyway. Yeah.
Is hereditary spherocytosis more common in certain populations?
No.
Okay, great.
Yeah, no, it's pretty ubiquitous actually. And as I said, it can be very, very mild to just being a thing down the microscope with perfectly normal parameters, or it can be very severe, needing to be a splenectomy. And the reason why taking the spleen out works is because I don't know if you remember, but cells have to squeeze through the splenic sinuses, and so they have to be that nice biconcave face. And when it's a sort of rigid ball, they don't get through the spleen. So taking the spleen out returns their lifespan to normal. Yeah. So should we go on to another case?
Yes.
So this, if you look at your algorithm, you can absorb the macrocytic pathway of the algorithm here, and because we've got a hemoglobin of 95, an MCV of 107, a white count of 3.9, neutrophils 1.8, and a slightly high platelet count of 406. And this is really important. Although the neutrophils are 1.8, and neutrophils of 1.8 on their own are neither here nor there. In fact, you can see the normal range in this laboratory is 1.9 to 7.5. And really 1.8 is kind of neither here nor there. So you'll want to look at the previous cumulative bloods just to see whether that's a thing or not. And remember I mentioned the MCH?
Yes.
So can you see that's high? So now you'll know it's high because the MCV is high. So it should mimic the MCV. So a big red cell should have more hemoglobin unless it's hyperchromic, which you can get as well. So it's good to look at both of those. And yay, the reticulocytes are done. I don't know whether Mark chose these cases just so I couldn't have a moan about no reticulocytes. But for that hemoglobin, in a 68-year-old is quite low, and so if it's bleeding or hemolysis, the reticulocytes should be well over 100. So we talk even about, although it's in the normal range, it's inappropriately low. So then you've got to say, well, what's going on here? So if you look at your algorithm, you can see the investigations that we're going to do. We love the blood film review. And so you can see it's quite a short list of tests that you can target. And the list in the differential is also quite short. So somebody with fatigue and anemia, you're going to do those tests. And the first thing you want to do is to make sure they don't just need some B12 and folate. Oh, that's all pretty reassuring, isn't it? Even by my standards. Now, just a little mention about B12. B12 is not, people think the lab don't do a good test, but the B12 that you have in your body is two sorts. Most of the B12 you have is just like useless storage B12. It just never gets off the couch. So it looks like it's doing a good job, but it doesn't. And then there's a little bit, what we used to call transcobalamin 2, and it's now called haptocorin or something. Beaver's round, like an Uber Eats, delivering small amounts of B12 very efficiently to everywhere. But when you measure B12, you don't know how much of the active Uber B12 you got and how much is just sitting on the couch B12. So I just think if you've got anemia and the B12 is less than 300, you should just give some B12 and see what happens, particularly in the elderly where your Uber B12 doesn't work so well. And you've got a folate there, which is plentiful as well.
Yes, the level I use is in elderly is 250. So
yeah,
obviously if that's coming in, I mean, it's normal, isn't it?
Yep. So 250, 300, I think it just depends what else you're not finding. Now you see here, she's had iron studies, her ferritin's fine, her saturation's high, and maybe because she's tired, she might be taking oral iron, because that's something. I'll come to some other causes why that might be the case as well.
Elayne, there was a question earlier about someone requesting if you could go through the iron panel and explain the significance of each one of those tests.
Yes, I'm going
as
to.
A refresher.
Okay. I'm
great.
At the end, I've got a little two slide thing on iron, which hopefully will help. Yeah. Okay, so don't panic. Don't panic about that. That's coming. So protein electrophoresis is really important. I can't tell you how many myelomas get missed, and it can be as subtle as a normal hemoglobin and a macrocytosis. And then if you put the clinical together, there's a bit of bone pain, the calcium might be a bit high, the renal function might be starting to go, or not. But if the B12 and folate are normal and it's in this sort of age group, you should really do a protein electrophoresis. If you've got more suspicion for myeloma, just jump in to do the serum-free light chains. Please don't ask for Benz-Jones protein. I'm really trying to can Benz-Jones protein in favor of serum-free light chains. In the laboratory, it's very labor-intensive. They quite like doing it because it's like an old-fashioned test that they quite like doing. But really, I haven't asked for a Benz-Jones protein in a few years, although the guidelines, when you're treating myeloma, say you should do it, and maybe on diagnosis of myeloma, looking for it does it, but we're finding it just doesn't contribute anything. So I would love to see Benz-Jones proteins shrivel away like the ESR has.
That's the take-home point, everyone.
Yeah.
Hope you've been listening.
Yeah. So no Benz-Jones protein. Do your free light chains, which they've done here, which is really good, and they're normal. And just remember, if they're both up, it's probably because the renal function's a bit off. So you're looking for an abnormal ratio. And we get a lot of referrals with, the kappa light chains have gone from 27 to 42, and the lambda light chains have gone up as well. And it really doesn't matter. So, and you don't really need to check both unless you've got really high suspicion.
So what will put up the free kappa light chain? So what gives you that, like you say?
That is irrelevant. the fact that it's in red is irrelevant.
Okay, so it's the ratio that's the key.
It's the ratio. You're looking for the ratio. Yeah.
Okay.
Yeah. So just because something's red, don't you hate it when people have access to the results and you spend hours explaining every little thing's in red? Oh, why is my serum iron high? Why is my serum iron low? Yeah.
I agree.
So there's urine Benz Jones down here. So I wish I had the skills to put a big cross through that. There are other things. You can certainly look at your liver function, renal function, thyroid, all those sort of things. But those patients aren't often anemic, so macrocytosis without anemia might well be liver. But yeah. So what you want to do is congratulate yourself for doing the reticulocytes and noticing that they're inappropriately low. And we'll just say all the other tests were normal, all the important tests were done. And then when you go back to the blood film, you say, well, the neutrophils are a bit low and there's a little bit of odd stuff going on. So if you can't find anything else, this is a symptomatic patient who may be a candidate for transfusion. She at least deserves a diagnosis. And so this patient did go to bone marrow biopsy and a diagnosis of myelodysplastic syndrome is made. Now, I could talk for hours about myelodysplastic syndrome, but just the take-home points here are that no matter what age the patient is, it's worth investigating. Please don't leave somebody who's 94 with a hemoglobin of 80 because she's old. I've seen quality of life transformed. I've diagnosed myeloma in people in their 90s and given them not an amazingly long life because they're coming to the end of their life anyway, but free them from pain, improve their thing, even if they just get the odd transfusion. They need to have the basics sorted out. They need to be offered a bone marrow, and before they get transfused, I think you've got to know, because sometimes it's a case of just giving them some tranexamic acid to stop their bowel bleeding, stopping their dabigatran or whatever. So that's just one of my things. I really advocate for anemia in the elderly. I sing in a choir, and when I go to rest homes and they're there, I can spot the anemic ones and I just want to take them home and sort them out. The remedy can be quite simple. So
before we move on from that one, I guess one thing I could contribute there as well, in terms of who does bone marrows, because from our training, it's always been the hematologists, and people live in places where hematologists don't come very often. And to my understanding, Elayne, you upskilled two of our rural hospital consultants, Tom Dawson and Hannah Lawn, into how to do it. So we can all be qualified.
Yes, you can. I mean, we do this for reasons that we find it really hard to accommodate all the bone marrows to be done. For a start, it's a long trip for patients to come through to Palmy. And then we had Kay Abraham in New Plymouth, who did them for a while, but then just got too busy and lost her heart for it. And so because Hara is that lovely sort of can drain from such a big circle, and there was enthusiasm, we're very happy to have Tom and Hannah come to Palmy, where we did a workshop for book 5 bone marrows in a day, because it is something that does take quite a bit of skill. We also did that for Helke in Hawke's Bay as well. So it is something that can be taught, but we believe nobody should be doing a bone marrow without accreditation and sign-off, because for a start, it can be very painful for the patients. The samples are generally awful. So it does need to be good, and for that you need a good laboratory. You need enthusiasm from your laboratory staff as well. So thanks, Mark. That's a good point. Now, this is a really lovely case, and thank you from
Dawn.
Yes, from Dawn for this case. It was really good. So this is a 74-year-old lady. She's tired and lost weight. She's been feeling extra tired lately, and this is not her usual self. She would normally go to the gym, and now she can just not walk much. She's lost quite a lot of weight, and this might be because she's got a reduced appetite. And of course, like a lot of times when people fall off the perch a little bit, it's always the jolly COVID vaccine, isn't it, that gets the blame. And really, I just shortened the history because a lot of the excellent history that was there revealed nothing until examination of the abdomen, which revealed a huge mass in the left hypochondriac region extending into the right inguinal area, so across the abdomen, non-tender, firm, and about the size of a large grapefruit. And I don't know what this lady looks like, but you must have huge grapefruits in Rarotonga.
Bigger than mine, that's for sure.
Bigger than on my tree as well. So it's definitely a large grapefruit.
Or very small lady.
Or a very small lady. Yeah, absolutely. And just a message here is always put the patient on the bed. The hematological examination is quite quick. So when you've got an anemic patient, you don't have to, you don't have to test their reflexes and their swallowing and all the rest of it. And so the hematological examination is check them for pallor, look for bruising, which they might not have fessed up to, take their temperature, and then lymph nodes, liver, or spleen. So, that actually takes 2 minutes. And basically, it's lovely when patients come dressed for a quick exam. Less easy when they've got layers and layers of clothes, hey?
Where do you feel for lymph nodes? Do you do, supraclavicular, cervical, axillary, and groin?
Submandibular, occipital, cervical, supraclavicular, axillary, groin. Yeah.
Thank you.
And again, once you've felt a spleen, you want to go back and make sure that there are no lymph nodes as well. And also you should be on high alert here because she's lost weight, lost appetite, and previously been very fit. And she's in the age demographic where something like lymphoma could be a thing. So when you've got a left hypochondrial mass, isn't that just your dream, is to feel a spleen? When we're doing exams, they always hit us up for some lymph nodes and spleens, and we do still have some despite our superb treatment. So we have a few patients who get roped in for that, and it's quite nice if it's not super huge, but it's just sort of like a hand breath below, and they have to do a nice deep inspiration. It's really nice. So these are the essentials of her. She's got a big spleen, she's pale, and she's got weight loss. So how are you going to solve this problem? And obviously you're going to solve this problem with a blood test. I thought you were all going to say bone marrow, but no, we can confirm her pallor, and she's got a normochromic normocytic anemia. But you don't know that she has a normochromic normocytic anemia because here they're not giving another really lovely red cell parameter, which some labs take out because it just creates confusion. And we'll see if anybody knows what that other red cell parameter is. The Howrah crowd should know. 5, 4, 3, 2, 1. It's the RDW. People say, oh, RDW. Oh, yeah. So that's the red cell distribution width, which is just a fancy name for what's the variation in the size of the red cells. Do they all look the same, like they're in the same class at school, or do they look some small, some big, some misshapen? So you can phone the lab and say, oh, by the way, what was the RDW? They will fall over. They'll think you're just the most amazing creatures on earth if you just ask them, what's the RDW? So we don't get that here. But apart from her anemia, her white count's high. Right, so you want to then know what the differential is. And automated analyzers are great, but they can also send you up the garden track a little bit as well. But the analyzers will tell you if they're not happy with the cells they're dishing out. So sometimes you have to wait a bit longer for the lab to actually do a differential. So there you have your diff, and if you notice with your diff, it's sort of, on the face of it, not hugely remarkable, and you were asking about the different white cells. So neutrophils are basically up with infection, inflammation, and so on. Monocytes are also inflammatory response, infection, inflammation. Eosinophils are up with, the differential of eosinophils is usually reactive secondary to parasites, allergy, atopy, few lung conditions, skin conditions, usually pretty obvious. But the big glaring one here, and this lab's unfortunate, is things don't shine up at you, so you actually have to read, which is really good for you. The basophils are very high, and the total numbers don't seem much compared with the other blood count, but if you look at the normal range of 0 to 0.2, 1.3 is going to make for a very exciting blood film. There are going to be loads and loads of basophils, and you've got quite a lot of immature granulocytes. So hopefully you know that immature granulocytes are...
Come on, Mark, you have to help me here.
I guess precursors to a lot of these cells, like ones
Yeah,
lineage up from
So
neutrophils and cells of dinosaurs.
Yeah,
So I guess a stem cell, but one step down from that.
Yeah. So
Partly
just a little
differentiated
refresher
stem
there.
cell.
Below the mature neutrophil is a band.
Myelose.
Oh, well done.
Oh.
Band.
Oh, yeah.
Yeah. Band. Metamyelocyte, myelocyte, promyelocyte, blast. So you really want to know more than just immature grands, because if they're all just bands, ignoring the basophils and eosinophils for now, that would be more consistent with infection. If you've got blasts and promyelocytes and myelocytes, that's usually hematological. So you really want to know. If you're looking with somebody who's unwell, a C-reactive protein is really useful here. If you've got a C-reactive protein of 200, the patient's going to be really sick, but then that would be like an infection. So with your differential, you want more than the immature granulocytes. You want it spelt out. You want to know whether they're blasts, promyelocytes, myelocytes, metamyelocytes, bands. I'm just repeating that just so that you can get them in your head. And if you got your phone, another device with you, and you look them up, they're super fun. And again, the laboratory would love to help you. So this is where going back really is helpful. And it also makes you kick yourself for perhaps not noticing back then. You don't know what her circumstances were in July 2021, but she had high platelets. Now, in a post-op setting, or if the patient's sick, that could just go by the by and be considered reactive, unless you look at a blood film. So this was the diff back then, and you can see they've done a beautiful, they've done a thing, and there's some myelocytes, metamyelocytes, and bands. So the more left shift you go, the more suspicious you get. Can you see the basophils were up then too, a smidge? But this is the time, and the neutrophils were up a smidge. So you really want to pay attention to this back then. And you'll see that the platelets had large and giant platelets. There was mild toxic changes, which might have been a bit of a diversion towards maybe having an infection. But can you see marked poikilocytosis? Poikilocytosis is different shapes of red cells. I always remember that, P for shape. And anisocytosis for size is just the way. it's easier to remember. But they reported some red cell fragments, and whenever you get red cell fragments and elliptocytes and all these sort of things, you really want to, and spherocytes. I'd love to see that film because this is an exciting film. And they thought this was consistent with hereditary elliptocytosis. The problem with that is that that doesn't cause your high platelets and your large and giant platelets. So in this situation, they're just focusing on the red cell changes, and that's okay. So I didn't put up the blood film from 2015 in the interest of time, but that also had a high platelet count. So you're looking like 7 years down the track, you're dealing with a hematological disorder that hasn't had any attention. So no wonder the spleen's enlarged. So when you've got a high count, a left shift and basophils, and large and giant platelets, it's going to be a myeloproliferative disorder. And it's very lucky this lady hasn't had a stroke or a heart attack or a pulmonary embolism in this time. And even if you've got limited resources to lower the platelet count and get the numbers right, even a little bit of aspirin can actually be really, really helpful in the setting. Now the blood film is pending. I see it's going to Lab Plus in Auckland, and that's going to take some time. And just a little trick here that maybe you can get your lab staff to have a play with is to get them to take photos down their cell phone. It's quite a skill, and you need a steadier hand than I've got, but it's very easy. So, for example, in Hawke's Bay, when they have a new leukemic, they'll phone me at night, and they will just send a couple of photos through to my cell phone, and have me explain the blood count. And I can say, oh, this is a child, those look like lymphoblasts, just phone Starship and transfer, start the process of transferring the patient to Starship. And then that means in the morning, the patient can be in Starship. Whereas if you wait for the film to get down to Dunedin or Waikato or Lab Plus or wherever, it's amazing. I mean, we're lucky from Gisborne, Taranaki, Hara, Wanganui, and Hawke's Bay. We have an overnight courier service and review slides. But if it's urgent, honestly, just get your lab staff to have a plan. Ask them if they can practice so that when it's urgent, they can just do that with confidence. That's what smart technology is all about.
So next level telehealth.
Yeah. I mean, the thing is, it is amenable because everybody now has a smartphone, even in the most rural settings.
Yep.
They'll have the internet and a lovely camera on their phone. And my registrars used to do all my presentations by taking photographs for me down that. Now I've got a camera, which is much better, and it's good for teaching. Which is another thing I can do Zoom lab teaching from my microscope now, which is quite good.
Yeah, neat.
Yeah. So basically, depending on your setting, a big spleen, weight loss and things can be like tropical diseases. So depending on where you are, in New Zealand, that would be extraordinarily rare, unless it was a new immigrant. But with those basophils and that left shift, chronic myeloid leukemia is really important to exclude. Now we've got 7 years down the track. If this was chronic myeloid leukemia, it would have transformed to an acute leukemia, and the patient would not have survived. So it's likely to be essential thrombocythemia, which is just the high platelets. And it's not just high platelets. I've seen gangrenous toes from the orthopedic surgeons where they've been treated for osteomyelitis. I've seen blue toes. I've seen ulceration. I've seen strokes, heart attacks, a lot of mischief. Migraine headaches is the other thing. Somebody was going for hyperbaric oxygen for treatment of their headaches, and their platelet count was only like 550. Put her on hydroxyurea, and she's completely headache free. So that's another, just a little thing that I found quite useful. Hydroxyurea is cheap, accessible, and it'll reduce the spleen size. And it's probably worth trying on in her, even although she's anemic, because part of that anemia, maybe who's tested her iron B12 folate levels? Maybe she's got other causes. Also, if you've got a big spleen, you get sequestration in the spleen, and that can make the anemia worse. So certainly worth that.
Okay.
And the other clue that you're looking out for on the blood film is the presence of teardrops. As soon as you've got teardrops and an anemia, you're dealing with a fibrotic bone marrow. And that can be primary, it can be the hematological myeloproliferative, or it can be I've seen lots of metastatic cancer with teardrops and a leukoerythroblastic blood film and low counts. It can be breast cancer, prostate cancer, usually. Yeah.
Okay.
Yeah.
Brilliant, Elayne. So we've probably got about 10 minutes left.
Yeah, that's all right. So basically, these are just my anemia tips. Don't forget your reticulocytes. Check your iron B12 and folate levels, and have a low threshold for replacement. Always worth a go, because you're going to wait for a bone marrow. It's not going to muck up our bone marrow either. You don't have to keep the patient B12 deficient to confirm megaloblastic anemia. We want that all sorted so we can say this isn't B12, this is myelodysplastic syndrome. So have a play with your algorithm, and adapt it. And I think it's there not to be on paper, but actually, if you get it into your brain is way faster. And you can actually, instead of doing this while you're seeing a patient, start filtering. And it's just practice. The other thing is examine the patient. And the other thing is, when referring cases for a hematology opinion, have a go. Just say, oh, what I want to exclude is this. So just show, and I think what you'll find when you get the response back, you'll get better feedback, and then you'll send us less referrals, and then we'll have a life. So this is all an investment to get
Absolutely.
to get you just to do it. And I do sympathize that you've got a million specialties that you have to condense down and just, I realize your library has to be paperbacks or paperbacks on a million subjects. Yeah.
So just one little question on that in terms of paperbacks, because we are out of paperback territory now. What I think intimidates a lot of rural practitioners is you get a blood film, and the ones that say all these fancy words and then at the bottom the diagnosis, great. But often you see all the fancy hematological terms without the diagnosis.
Yes.
And then what the concern is, I guess leukoerythroblastic film, that's a red flag that we should pick up and act on.
Yes.
But it could,
but the laboratory should be sending that through to a hematologist for a comment.
Okay.
And if they're not, you need to put with your next blood test or that one, say, please refer that film to a hematologist for comment, because again, that saves a referral. And to assess it as a film, it still takes us quite a lot of time. We have to go through all the background. The other thing is, please put a little clinical detail on your form. Like, these cases are wonderful, because a lady who's like lost weight and got a splenomegaly is like a completely different kettle of fish to a routine health check, or even if you put routine health check. But so often we don't know whether they've come for a viral illness or whether they've got sweats, just like SOB, chest pain. Like, it doesn't have to be like 3 pages, but honestly, like query jaundice, gold. I'd really encourage you to put something on the blood test forms. I wish I could give a chocolate fish for every time there's a cry.
I was just curious, Elayne, whether there's something like an online database or a website that people can use to maybe, get some information about when you get a blood film that has all these terms, apart from Wikipedia, because it just seems unprofessional.
Well, basically, I think you'll just get bogged down. I would just email me. You're very welcome to. I've got my email address at the end, because I actually love helping that, because I only have to do it once, and then hopefully it's empowering and everything gets easier and better. So I do a lot of screening for the iron deficiency pharyngeals, and I do it sort of without too much sweat. And it can be quite simple. I think there's a lot of information, but I don't know if anything like really condensed. There are some lovely little hematology books that show blood films, but yeah, if I do come across one, I will share it. But I think you just get bogged down when you Google, don't you? Yeah. So we're just going to do a little bit on iron if you've still got some energy. So basically, iron deficiency is easy if it's unequivocal, and that is a ferritin of less than 20. The problem is the grey zone ferritins. And that's why I'd encourage you to do full iron studies at the outset and with the CRP, because they are both, then you're doing it in one hit. I mean, if you've got a 16-year-old who bleeds for 28 days of the month and whatever, you probably don't need to, but particularly in the elderly where so much else is going on, you want to interpret your ferritin and the need for iron replacement in the context of chronic disease, heart failure, and renal failure. So I guess in terms of interpreting iron deficiency, your ferritin of less than 20 is unequivocal iron deficiency. If you've got a ferritin that's under 100, but your saturation is low, less than 20%, so it's sort of the rules of 20, really. In Australia, it's 30, I think, but we're 20 here. If your saturation is less than 20, and if your CRP is high, you haven't excluded iron deficiency, and iron replacement is probably worth a go, particularly if the patient's got renal impairment or heart failure. And I think you'll know that iron replacement is, particularly parenteral iron replacement, is supposed to improve heart function quite significantly. So spare a thought for all your little 80, 90 and 100-year-olds, that you can actually give them a real boost, and maybe they'll go tramping and, you know, round the block at least, with a little bit of new joie de vivre. I guess parenteral versus oral iron, you're supposed to declare that the patient is intolerant of oral iron, and really oral iron is really cheap, it's convenient, it's resource easy. You know, all these parenteral irons are sort of blocking up the system when there's so much else occupying nurses and practices nowadays. So my little sort of take-home thing is just ask them to take 1 ferritab a week, and then say, well done, try 2 now, you know, like, aren't you doing well? And there are often other reasons for the constipation and the things. They're often unhappy and tired and not eating all that well and everything. So I think if you coax them, and it's a bit like having a routine cesarean section because you couldn't be bothered to push, you know, like, and it's convenient because you get it on the day. It depends on the severity of the anemia and so on, but actually just think about that. And the other thing is, don't just keep topping up without working on the cause. Sometimes, you know, a friend of mine just had anemia and got put on iron, felt fantastic, and then 2 years later had this enormous bowel cancer diagnosed. So you do need to work on the cause, and keep looking for the cause as well, because on the first pass it might certainly be missed. I mentioned checking your B12 and folate levels, and the other thing on iron replacement is if you do give Ferinject, and there was a question around this, like somebody saying they have, you know, like it seemed like then, in fact, it was a referral, they needed to give 3 or 4 iron infusions, and although the hemoglobin was 130, the ferritin was still on the low side, it was only like 30. And this was somebody who had a hemoglobin of 60, an MCV of 63, and a ferritin of less than 2. Now, to replace that ferritin, you're not going to get it on 1,000 milligrams. And that other question about that discrepancy about 1,000 maximum and then 1,500 maximum. Per infusion, it's 1,000 milligrams, but that might not be the total dose you required. So if you think it's a severe iron deficiency, you can even routinely book them 2 weeks later for a second iron infusion. But if you've solved the problem and they can go on to iron, you might only need one. So I always just think start with one, but have a very low threshold for saying, I don't think this is going to be enough. And I'm sure that's the cause of a lot of the relapsing iron deficiency, even if you've corrected the underlying cause. Does that make sense?
Yes. Yep. Thank you.
Yep, so that's all right. So you don't want to mask that. So just a quick thing on high ferritin. Interpreting iron studies is tricky. For a start, serum iron means nothing. So we still occasionally get referrals, please see this patient, the serum iron is 7, and then you look down and the ferritin is 450. And obviously the saturation is going to be low. And that's because the serum iron is low because it goes down in inflammation and infection, and it's sort of like a negative acute phase reactant, if that makes sense. And there's a lot of diurnal variation. So ignore the serum iron, but do look at the saturation and the ferritin. If you've got a high ferritin and a low saturation, that can be anemia of chronic disease, or in chronic disease, the saturation can be normal. If you've got a high saturation and a high ferritin, then I think you need to check the patient again when they're well. So say you've done this after an alcohol binge, or they've had a viral illness, or they've just been in hospital, or had a blood transfusion. You don't actually want to panic at that point. You want to recheck things in the cold light of day, and just consider fasting bloods. It just takes a little bit of the diurnal variation out. And when you are repeating it, check your liver function and include the GGT, because I tell you what, alcohol has a big part to play in high ferritins. And you know, they'll say, oh, I don't drink much. Somebody says, I only drink 12 bottles a night. I've got a man with who drinks like probably 3/4 of a bottle of whiskey a day. He's a Scottish man, and he's not about to give up anytime soon. And so therefore you take his ferritin with a pinch of salt. You might know him, Mark. He's a regular tender for venesection because he does have compound hemochromatosis.
Now, there's a question in the list there, Elayne, that comes up here, which is, what's your normal duration between, say, if someone comes in with a viral illness, has abnormal iron studies that were a bit concerning with high saturation, or say they had an unusual full blood count? How long do you normally wait to see that bounce back to normal?
I think 4 weeks, because your solution isn't urgent. And if in the meantime, especially, you can take an alcohol history and ask him in that time to address their lifestyle. And if you show patients their liver function and their irons and things, it does shock them somewhat into behaving a bit better.
Absolutely.
And you know what I say? I just say go for the 0% options, because often it's a social, it's a social commitment that that nowadays is really easy. In fact, when I went to visit my daughter in London, I was the only one drinking at a lunch party she had, and they were all drinking 0% champagne, 0% wine, and 0% beer. I felt very hedonistic with my alcohol consumption, and I thought, well, it's lovely that there's those options now. So I think you're not in any hurry. Obviously, if their ferritin is 3,000 and their saturation's 100% and their liver function's abnormal and they're not post-hepatitis or something, then you're going to do it. But the sort of grey zone areas between 500 to 1,000, and you really need to look at your saturation. If your saturation is less than 45%, it's highly unlikely you've got hemochromatosis. Highly unlikely.
Okay.
And in fact, some of the recommendations say you shouldn't even look for hemochromatosis gene studies. You might do them and you might find that they're just heterozygous, and then persuading the patient that they're only heterozygous and their clinical risk is low, they become obsessed with their ferritin level. And sometimes we just get bullied into venisecting them, which is a shame, when actually they should be addressing their lifestyle factors. The other big thing is fatty liver. Fatty liver is a very common cause, and I think that might be on. So basically, if you've got a low saturation and you in the grey zone, and that you're going to test them, because a blood test is easier than arranging a liver ultrasound, isn't it? But you'll do it and they'll say echogenicity consistent with fatty liver. And it often goes with this sort of metabolic syndrome patients. You can sort of look at them from the end of the bed and just say, yeah, you've got a fatty liver. And they just need to get their lifestyle. And I think that's the problem in general practice. You've got so much lifestyle stuff to address. My guideline, I had that algorithm, which I'm sure you've probably seen. I still quite like that algorithm for management of the hemochromatosis patients, but I've fallen a little bit out of step in that it's become a lot more permissive, because the guidelines say people's quality of life in the studies was probably favoured venesection, and I think that's a bit. Like when you're bleeding on the battle, there's a sort of euphoria after being bled and a sense of well-being. And people will come and they'll lie on the floor with a ferritin of 34 saying, I need my blood off, I really need my blood off. And it's really difficult to persuade them otherwise.
Okay. How many more slides have you got, Elayne?
I think that I've just got a final. Yep, I've talked about that. And then I've just offered my email address. I might regret that. But
you just may, Elayne.
But I am happy to help, because often the answers are my answers will be quick and simple, and pragmatic.
No, absolutely.
And I won't
be.
give you a dissertation on anything complex. It'll be like a three-step help plan. I do have algorithms on other subjects, which I can introduce with the talk at another stage, or I can just send them all to you. I think I prefer to do them somewhat in context, because otherwise, without a little bit of background to their use, I find that they may not mean as much. But anyway,
yeah.
so.
I can understand that. Some explanation of an algorithm is a lot more useful than necessarily. But they can be very good. Like everything, they're good guidelines, aren't they? But they do involve them.
And I don't know what you find about your health pathways, but some people find the health pathways a bit complex to navigate, depending on the subject. I haven't looked much at the health pathways, but sort of medicine is becoming very algorithm driven. And I think basically they should just be a guide to your brain, really.
Absolutely.
Just sort of, and the more experience you get and the more you practice hematology as well, it sort of just becomes intuitive, like what the most likely scenario is. So good luck with your hematology, guys.
Absolutely. It's Elayne, your talk this evening when you've said what would that be, and I'm like, oh, just sitting here looking extremely blank. So I must admit, though, I do remember looking up and trying to remember the myelocytes, metamyelocytes and things, and I remember drawing pictures of them all, and then the whole go through. But it's now so distant, it's too long, so it's completely dropped out of my brain.
When you see those film comments and you see occasional myelocytes, ka-ching, just
I'll be like, Elayne, I still don't remember. But I'd like to say thank you very, very much. Susanna, maybe you could email Elayne if you don't feel like your question has been answered. But otherwise, I'd just like to say thank you very, very much to Elayne, and also to Mark for helping this evening.
Yeah, thank you for your cases, Mark.
And also apologies about missing the first few minutes.
We all understand. We all understand. Thank you to everyone who has come this evening. If you can fill out the survey that was just further up in the chat, that would be much appreciated. I will link it back in, and then I can lodge your CME points. I'll just copy that. And I hope everyone has a very good evening, and thank you very much.
And tomorrow's Tuesday, which is good.
Yes, short week.
Short week, yeah. Thanks,
There's
everybody.
the link, everyone.
Have a lovely evening. Bye-bye.
Bye. So Elayne and Mark, if you hang around, and Hannah, if you'd like. Evening, everyone.